Hi, thanks again. How are you? This is Mohammed Musa from AFK Study Plan. Today we are going to continue the articles from NDEB website. We speak before about the articles covering the periodontic treatment, pulpotomy, pulpectomy. Feel free to watch the videos here from the links and feel free for sure to share these videos with your friends going to exam or studying this one or don't know about this perio classification, which is our topic today. Today topic is important. You will have question about this one for the last 4 or 5 cycles. You will be faced by at least 4 or 5 questions about this one. Some questions are extremely easy. Some questions a little tricky. You need to understand the concept, how you gonna differentiate, how you gonna say it is stage B or stage 3. So with that being said, let's go deep for this article. So first, we're going to start with end in mind. What are our goals today? Our goals today for you to know the new classification, for you to differentiate between health, gingivitis, and periodontitis, and which parameter we are going to use to say which is which, and then how to grade and stage disease. If you say it's a periodontitis, so you need now to conclude the stage for this one and the grade. And at the end, we're gonna speak about the implant health. But before we go deep for this one, I know for sure you know this terminology. Just a quick recap will not hurt anyone. So this is a diagram speaking about the structure, anatomy of the tooth and how you're gonna think about it because we're gonna speak about this a lot. I think you can see here the difference. It has like cross section and the other facial profile, so you can see where is the attached gingiva and whatever here is mentioned. I know you know it, but I would like you to recap again here for the two main points, the junctional epithelium and free gingival margin, because we're gonna need this a lot in the article. Junction epithelium is the part of the gingiva which is adherently attached to the tooth by more than one mechanism. This is not the way, this is not a place we're gonna speak about this mechanism, but you should know this one, junction epithelium and the level of junction epithelium and its location considering the cement-to-enamel junction is extremely important here. And then you're going to speak about free gingival margin. And then you see here the difference between the mucogingival junction and free gingival margin. Mucogingival junction is more apically. It is the part, it is the line differentiating between the gingiva attached to the periodontium and the loose gingiva, which is down, just covering the alveolar mucosa, but not attached to it. And for sure, you can see the root cementum and periodontal ligament anchoring between the root cementum and the alveolar bone from inside. And the alveolar bone has two type of bone, compact bone and trabecular bone. Compact bone is the bone facing the PDL and cementum, and the trabecular bone is the bone inside, giving it the elasticity and giving it nutrition. Okay. Again, here we're gonna speak about normal anatomy again. The probing depths. What is the probing depths? Because this term we're gonna use it a lot in the article so you can understand it. The probing depths usually it's 3 mm or under. Without any bleeding is generally accepted as healthy. So if you have patient, you introduce a probe inside the sulcus for sure with a center pressure, not like pushing it very hard, and the probe depth was up to 3 mm with no bleeding. You're gonna say, okay, this is good. So you have healthy periodontium here, and there is no attachment loss. If you have bleeding, if you have more probing depths, so you're gonna think about different scenarios and we're gonna speak about each scenario separately. Then here you can see the junctional epithelium and the connective tissue cementum, same as previous slide. I just want you to think about it and to imagine it. Okay, and then we're gonna speak about clinical attachment loss, which in short say CAL, occurs through the destruction of periodontal ligament and its adjacent alveolar bone, subsequently leading to gingival recession and pathological periodontal probing depth. Pathological here is important because like not every probing depth more than 3 you consider it as periodontitis. You might have different scenario. I will let you know about this scenario later. But here the critical point, the probing depth is more than 3 mm and the depth of the pocket is way apical of cement to enamel junction, is going more than cement to enamel junction. And here is, you can think about it, okay, so clinical attachment loss for sure will be the same as probing depths. No, not in every case it will be the same. Why? As you see in the diagram, the clinical attachment loss is the space between the cement to enamel junction and the depth of the pocket, while the probing depth is the distance from free marginal gingiva till the depth of the pocket. So you can see the pink line and the green line. Green line, regardless of the gingiva, is the space or the distance from cement to enamel junction to the depth of the pocket. And the other one, including everything, this one and the other one, which is starting from free marginal gingiva. If the free marginal gingiva is going apically beyond the cement to enamel junction, so you will have different criteria, which we can call it as a recession, which you can see now here. Gum recession is the apical migration of the marginal gingiva and is gradually displaced away from the cement to enamel junction, thereby exposing the root surface to the oral environment. Here you can see the recession is the space between the cement to enamel junction to the free gingival margin. While the clinical attachment loss is still the same, it is from cement to enamel junction to the depth of the pocket. So in this case, the clinical attachment loss will be more than probing depths. So I give you case with the clinical attachment loss is 6 and you have the probing depths of 5. So when you think about it, so you know for sure this case has a recession. Otherwise, if I give you this number with the probing depths is different, so you're gonna think a different scenario. Why I'm repeating this, I want you to see the picture and like think about it and visualize it, because this will be critical when you see numbers, not to jump to conclusion. You need to pay attention to the numbers and see which is which. So to wrap it up, normal probing depth is 2 to 3 millimeter. When it is more than 4, it might be a periodontitis. And recession is from cement to enamel junction to the crest of the gingiva, and clinical attachment loss is the probing depth plus recession when you have a recession. So if recession is 0, so you can say clinical attachment loss is a probing depth, same as probing depth, but you cannot say as a rule. You should read the question and answer it according to what you have. If you have a recession, so you're gonna add it to the probing depth to reach for cal. If you don't have it, so it's good. So, and here is a picture giving you the back to back, like in front of each other. So you can see 5 millimeter clinical attachment loss with 4 millimeter probing depth, meaning we have a recession, which is 1 millimeter as clinical recession. Okay. So that was the terminology. I would like you to go back to it if you don't have clear understanding about it, because like you're gonna need this terminology a lot here. So we're gonna say the periodontal disease and condition. We're gonna make it in 3 main categories. First one is a periodontal health with gingival disease condition. Second one is periodontitis, and third one is other condition affecting periodontium. And then we're gonna speak about the implant. Okay, so let's go one by one. I don't want to bombarding you with information. I want you to go step by step. Before we proceed, we need to know which parameter we are going to use to say this gingivitis and which parameter we're going to use to say this periodontitis. So to wrap it up in a nutshell for you, gingivitis is a factor of bleeding. Gingivitis is a factor of bleeding, while periodontitis is a factor of attachment loss, clinical attachment loss. Gingivitis is a factor of bleeding, while periodontitis is a factor of clinical attachment loss. Meaning, definition of a gingivitis case, it agreed that bleeding on probing should be the primary parameter to set threshold for gingivitis. The workshop also characterized periodontal health and gingival inflammation in a reduced periodontium after completion of successful treatment of a patient with a periodontitis. Meaning, like, you might have a periodontitis patient, you give him treatment, he's good now. His good now meaning is not going more, because if you have a periodontitis patient, he's a periodontitis patient for life. Meaning, as periodontitis, we agreed the parameter for it is the clinical attachment loss. You know for sure bone cannot go up. You cannot say, okay, bone is done and then bone go up. No, you should do some surgery to induce the bone to go up. And if you think about it, it's a very simple equation. You have in the sulcus area, you have bone and you have connective tissue. Think about it like this way. The bone is the turtle here, and the connective tissue is the rabbit. You have a space, you clean it, it's biologically accepted now, so you have a race between a turtle and a rabbit. So in most cases, for sure, as you know, the rabbit will win, so the gingiva and soft tissue will take over the bone. So anyway, the bone cannot go up, cannot go vertically without any surgery for you to do. So periodontitis patient is a periodontitis patient for life unless you intervene with him with a surgery. It was accepted that a patient with a gingivitis can revert to a state of health, but a periodontitis patient remain a periodontitis patient for life. And the reason, I hope you understand it now. Okay? So let's start with a periodontal health and gingival health. We're gonna speak about the healthy condition so you can differentiate between healthy and gingivitis and subsequently periodontitis. Clinical gingival health on an intact periodontium is when you can say this terminology when there is absence or minimal level of clinical inflammation in a periodontium with a normal support. Meaning, like this picture, gingiva is good, color is good, stippling is evident. If you do probing depth, you will have 2 to 3 maximum. Bleeding is less than 10 millimeter, less than 10%. You cannot say bleeding is null, this is not human. This means like he has plastic, not gingiva. Bleeding up to 10% of the location of while probing is accepted, and you can say, okay, this is a gingival condition, clinical gingival health on an intact periodontium. So if I tell you we do probing depths for a patient, the maximum probing depths was 3, and the clinical bleeding on probing was 9%. So what's the diagnosis for this patient? And then you have two more scenarios. Clinical gingival health on a reduced periodontium, which you're gonna say it's a stable periodontitis patient or non-periodontitis patient. And this is, here we go with a new guideline here. So not every recession, not every clinical attachment loss can be happen due to periodontitis condition. No. And how we gonna differentiate about it? So the main criteria here, if you have the clinical attachment loss or the increased probing depths interdentally between two teeth, so you might think this, you would lean more as a periodontitis condition. But if you have the increased probing depths and recession as you can see clearly in the last image, mid-buccal, so your mind going to think about different aspect. Think about this way. If you have a disease, this disease is affecting the whole area, so the bone loss will be evident interdental and buccal and lingual and everywhere. But if you have external factor affecting this soft tissue, so the external factor cannot go interdentally, it will go just from the buccal side or lingual side, giving you this picture at the end. I think you can conclude now what this picture. This picture is most likely a patient with aggressive brushing using hard toothbrush, thinking he giving him a good favor by doing and think this is good. No, this is not good. As you see, it's evident on the canine, and even in the fore, you see a recession. You see even cervical caries or not caries, cervical loss of the tooth structure, and even in the bridge after it, you can see the gingiva is going away. So it will be like affecting not one tooth, not more than one tooth. So you can say this patient has clinical reduced periodontium, but non-periodontitis patient. So read it out now. Stable periodontitis patient, periodontium with attachment loss from a previous periodontitis. So maybe this patient had a periodontitis before, you give him cleaning, you give him oral instruction, he is following it, so the attachment loss is not progressive. If the attachment loss is still progressive, so you're gonna think about this patient as a periodontitis. Periodontitis patient who undergo successful periodontal therapy or minimal inflammation and optimal therapeutic response with control of modifiable risk factor. So this patient is not at risk to be in more advanced periodontitis condition. He is controlled now coming from previous periodontal condition. Or non-periodontitis patient, clinical attachment loss with absence of clinical detectable inflammation. Example, patient with gingival recession due to forcible tooth brushing or following crown lengthening surgery. So I think you can differentiate now between these two. So to wrap it up, I will give you this beautiful graph or table, you can read it. So we're gonna say pristine dental periodontal health, clinical periodontal health on intact periodontium, gingivitis, and then periodontal disease. As we said, like it is the factor of bleeding is what we're gonna say it's a gingivitis. So in bleeding on probing, first two, it will be no to minimal. Gingivitis, yes, meaning more than 10%, and periodontal disease, no or minimal, and periodontal disease remission or control be significantly reduced. Normal gingival sulcus in first two for sure will be good. Gingivitis will be the same. Periodontitis for sure will be more than 3. Normal bone height in the first 3 category will be fine because there is no clinical attachment loss. In the last 2 category with periodontitis, it will be for sure not controlled. It will be less. The bone level will go epically more. Modifying factor, you can control like the brushing, the smoking, stuff like this. And the other one may be present, like for gingivitis, he has smoking habit. Maybe the patient is pregnant, so factor you cannot control or maybe present. For periodontitis, if it's not fully controlled, so he is still in active disease condition, if you can say it. If it's controlled, so meaning like patient is smoker, and then he goes for periodontitis, and then he's trying to cease the smoking or reduce number of the cigarettes he's doing every day. So you can say in a way it's a control. Okay. So this is everything about the first category is a periodontal health. Second is gingivitis. As we said, gingivitis is a factor of bleeding. And I would like you to think about it. It's not like today your patient is clinical health, tomorrow he's gingivitis, after tomorrow he's a periodontitis. Think about it as a journey. If you are taking an aeroplane from Calgary to Toronto, so you can say I am in Calgary exclusively or in Toronto exclusively. It's a journey he will go. Like think about this way: clinical health is Calgary for sure because I live in Calgary, and he's going in a journey which is gingivitis, going over Saskatchewan and stuff like this till he reach Toronto where he will have periodontitis. So it's a journey. It's not like one step to go to the second step. This is for everything in your body. It's not like today is green, tomorrow is orange, after tomorrow is red. So he here speak about like the risk factor he giving in this diagram is very beautiful, giving you the information. I would like you to read it and go through it because like I don't want to waste your time, but to know here, gingivitis has a rule of antibody with PMN, T and B cells, antigen, and then if you go for, like, if your body is trying to predisposition health response, because body will not say, okay, I have calculus here, plaque, and I will do nothing. No, body will fight again. If body cannot find it, or you don't have your oral measures, so the BMNs will increase, and then you go to more advanced of inflammation, which will induce plasma cells. Plasma cells will induce more antigen and virulence factor, leading to more destruction, and then connective tissue and bone damage, and then you go to chronic cytokines will appear now, take into place, MMB will go, and the story is very long. I cannot explain it now because the video will be extremely long. We here now want to speak about the general guideline of the new classification. If you would like to know more about this one, we can make a separate video for this and we can discuss this topic. Okay? So gingivitis is associated with dental biofilm alone. So you have two scenarios for gingivitis: associated with dental biofilm alone or mediated by systemic or local risk factor. And before I read it, I want you to know for sure whatever is going to be read now is associated with a dental biofilm. It's just dental biofilm alone or dental biofilm with systemic or local risk factor. So when I am telling you there's puberty gingivitis, you cannot say puberty gingivitis is due to the hormone change due to puberty or pregnancy. No, it's induced by dental biofilm and then is modified by systemic or local factor. Because I see a lot of dentists is confused. They think, okay, pregnancy is a reason for the gingivitis. No, the reason of gingivitis, if a question clearly asks you what is the etiology of pregnancy gingivitis, it is the dental biofilm, but not alone. It is modified by others condition. What condition that can modify this and qualify it for to be in the other category is B category: sex steroid hormone, puberty, menstrual cycle, pregnancy, oral contraceptive, hyperglycemia, hypoglycemia, leukemia, smoking, malnutrition. And if you think about it logically, this all criteria will induce more bleeding, will induce increased inflammation in the soft tissue, which lead to more profuse bleeding. So we cannot say it's gingivitis only. We should give it more criteria, okay? And then other stuff like oral factor enhancing plaque accumulation, which is prominent subgingival restoration margin or hyposalivation. And I want you to know this information for sure. Hyposalivation is not related to age. Like you cannot say every old patient will have hyposalivation. Hyposalivation is a factor of drug or condition the patient has, like Sjogren syndrome, he's taking some drugs leading to hyposalivation. So you cannot say for sure. It's not like, we know for sure, like when patient grow old, you see like gingival recession because like You think about it, the tooth is going up, he lost some teeth, the tooth is moving, so the gingiva is less and go apically. So you see this, like when you speak about the pulp, so you know the pulp have more fibers, less collagen, so you know this stuff. But for hyposalivation, it's not mandatory for every patient getting old to have hyposalivation. And C is drug influence gingival enlargement. And there's the third category. Okay? So I would like you to differentiate between these three categories and the category we're gonna speak about it now. Gingival disease of non-dental biofilm induced, which meaning this condition will have gingivitis regarding of the level of plaque control, regarding the factor of plaque here is obsolete. It has nothing to do with it. It has other factors leading to gingivitis, leading to inflammation in gingiva and bleeding, which include genetic or developmental disorder, specific infection, inflammatory and immune condition, reactive processes, neoplasm, endocrine, nutritional and metabolic disease, traumatic lesion, gingival pigmentation. So the bottom line here, this condition has nothing to do with a plaque control, stuff like this. So if your patient have lichen planus, if your patient have lichenoid reaction, if your patient has erythema multiforme, it has nothing to do with the plaque control, stuff like this. You should think about different stuff. So this is a different category between them. Let me go recap it again because this is very critical. I would like you to know it. Gingivitis is two categories. First one associated with dental biofilm alone, and then we're gonna modify it and add systemic or local factor. Or this category include also factor enhancing plaque accumulation like prominent gingival restoration margin or hyposalivation. And the second category is not due to the plaque at all, is due to other factors other than plaque, which is genetic, developmental, specific infection, inflammatory immune condition. And this categories is like solving a huge dilemma. We had it before. You say it's acute gingivitis, chronic gingivitis. It's not anymore. You cannot say it's acute gingivitis or chronic gingivitis. You say gingivitis based on bleeding, and you say it's gingivitis due to local factor, systemic factor, or due to drug he's using, or due to overhanging restoration, or you say it's gingivitis regardless of the plaque control, non-plaque induced. And then you're gonna speak about periodontitis. Before we dig deep in periodontitis, let's get rid of some stuff. Say, okay, this is a periodontitis, and then we're gonna speak about periodontitis at the end. So first three categories we're gonna speak about is necrotizing periodontal disease, which including before it was NUG and NUB. Now they are saying necrotizing gingivitis alone and necrotizing periodontitis. Before they say it's acute and chronic, now it's not anymore. And necrotizing stomatitis and periodontitis a manifestation of systemic disease, which this one will be equivalent to the other category of gingivitis. Gingivitis not due to plaque, including Down syndrome, leukocyte adhesion deficiency, Peplonephorn, and other conditions, severe neutropenia, congenital neutropenia, cyclic neutropenia. And this other condition is leading to periodontal loss, leading to bone recession, leading to bone destruction, leading to gingival recession without going to the cycle of gingivitis, going to periodontitis. So this patient, he used, you know, this loop about Elon Musk speak about it. He used it to go from Calgary to Toronto. He didn't use airplane. He was in Calgary in 1 second, next second, he was in periodontitis in Toronto, leading to this without going to show gingivitis and stuff like this. Okay. Okay, so periodontitis, we're gonna get rid of the three categories first, which is necrotic gingivitis, and we used to call it a different names. I don't want to like say the previous name because I know the previous name will stick in your mind. Just try to think it about as a blank page, specifically for dentists who getting used to the other category or other classification. I don't want to mention it, don't to confuse you. I would like you to understand it as is here. So it's associated with malnutrition, tobacco use, and stress. In this case, you will see more than bleeding. You will see specific criteria like will push you to say it's not gingivitis, it's necrotizing gingivitis. Necrotizing meaning like necrosis. Necrosis is loss of soft tissue. That tissue will have punctured out papilla, crater-like depression at the crest of interdental papilla. Gingival crater is covered by a gray pseudomembranous slough surrounded by erythematous margin. In this case, you will have no clinical attachment loss. Lesion bleed easily. It's painful, have metallic foul taste, may be associated with lymphadenopathy, leukocytis, fever, or malaise. Spirochetes, Tribunoma pallidum specifically, B. intermedia, and fusobacilli is the criminal arch here. So it has a lot of bacteria involved, but this three is the criminal here. And if I ask you a simple question, giving you this option, three option, asking you to choose which one is the criminal here, is the main criminal, is the one wanted to get rid of, is the Tribunoma pallidum. And this is, we can speak about in my microbiology lecture, why this one is the criminal here. It's a different topic. I don't want to waste your time here, but to cut short for you, NUG, necrotizing gingivitis, the criminal is a spirochete, Tribunoma pallidum, okay? And then we're gonna speak about it. It will be introduced more. Oh, let's have some picture here. So as you see here, this is not gingivitis alone. So you cannot say NUG from picture only. Clinical appearance plus patient giving you history of a stress, malnutrition, foul odor, bleeding more than usual. And I bring this X-rays because there is a little debate about it. I'm not going to dig deep in this debate. It's critically important that you know the difference between NUG and NUB is a bone loss. If you have bone loss, you're gonna say it's NUB. If you don't have bone loss, you can say it's NUB. It's a NUG. It's necrotizing gingivitis, not necrotizing periodontitis. Okay? And as you can conclude now, in this condition or in this category, the attachment loss will appear in different form, meaning as this condition is aggressive, it will not go through the normal steps of gingivitis and then periodontitis. The infection here is modified by other factor inside the patient, lifestyle, stress, malnutrition, and stuff like this. So the destruction will be severe. So in this case, in necrotizing periodontitis, you will have shallow probing depth, but you will have severe recession. So I hope the picture will explain this more. And when you go to the picture, it will so easy to think about it. As you see here, look at the gingiva. You cannot see much gingivitis. You cannot see like bleeding. You cannot see the gum is so red and inflamed, but you can see the gum is receded like dramatically. The gum here is so receding, going apical like crazy. Why? Because this condition is aggressive. So it will induce bone destruction fast. When the bone destruction happening fast, so the probing depth will be normal, it will be 2 or 3, but the recession will go crazy. So let's read it out loud now. So in necrotizing periodontitis, similar to necrotizing gingivitis, plus clinical attachment loss and bone loss. Deep interdental osseous crater. For this one, most commonly it happens in immunocompromised patient. It will not happen in like normal patient. Normal patient may have NUG, maybe have necrotizing gingivitis, but like if he's immunocompromised, he may progressively proceed to the next step and go to necrotizing periodontitis. Okay? And then if this patient is severely immunocompromised, the last one is necrotizing stomatitis, meaning this patient has a severe immunocompromised condition. The recession not will go to the mucogingival junction, it will go beyond mucogingival junction. And in this condition, it's very rare. You cannot see it in your clinic frequently, but this means this patient has severe immunocompromised condition, leading to infection going more and more fast without giving him any mercy about this one. Okay? So as you can see from what has been said now up till now, we didn't speak about periodontitis. We speak about everything except periodontitis, and this is a conclusion I want to give you here now. So in this article and this new way of thinking, they thought, okay, before we used to say acute periodontitis, chronic periodontitis, generalized periodontitis, localized periodontitis. Now we gonna take away every chance, every condition, every scenario leading to clinical attachment loss, leading to bone recession. And if we cannot say this clinical attachment loss, this gingival recession, this bone receding down, not due to anything of those, so we're gonna conclude this is a periodontitis patient. So if you have a recession, you don't jump say, okay, it's a periodontitis. No, it can be different stuff. So you need to go to medical history to read the question very carefully. If you have attachment loss in two location, not adjacent location. So in this condition, and you cannot see overhanging restoration, you cannot see systemic condition, you cannot see this patient has history before of periodontal treatment. So you're gonna say, okay, this patient now is a periodontitis patient, and then you are mandated to go for staging and grading to say this periodontitis patient is stage 1 or 2, 3, 4, and grade A, B, C. So with that said, let's now speak about periodontitis as a staging and grading. Staging will address the severity and complexity of the management. So staging, we're gonna say stage 1 would be initial, stage 2 moderate, stage 3 severe, and stage 4 severe with a potential loss of dentition. And then we're gonna say it's localized, generalized, or molar incisors. Molar incisors used to be called different one. I'm going to speak about it now. And we're gonna speak about grade. Grade is evidence of rapid progression, meaning like patient has risk factor. We're gonna say, okay, this risk factor is low, so we're gonna say it's a grade A, slow rate of progression, or B, moderate rate of progression, or C, rapid rate of progression. And for sure, you can conclude now, we're gonna do stage and grading because we want to know what's the next step for this patient. So to wrap everything up for you, so we suspect a periodontitis patient, like go from the upper left side. We suspect a periodontitis patient. First of all, we're gonna check local factor. If this patient has local factor, yes. So you think about 4 steps. Maybe he has endoperial lesion, maybe he has vertical root fracture, maybe he has caries or restoration, maybe caries extending subgingivally or restoration subgingivally or impacted wisdom tooth. So if you have this 4 condition, it's not a periodontitis. So you're gonna speak with them. You're gonna, okay, so let's deal with them in a different perspective. If it's no, and your clinical attachment loss happen in more than in a non-adjacent tooth, so you're gonna say, okay, it's a periodontitis patient. If it's happened in 2 location, like kissing location, adjacent, so you're gonna say it's gingivitis, and you're gonna monitor this one. Okay, so this is the rationale about this diagnosis. We're gonna conclude everything before we say periodontitis. So if we have 2 non-adjacent teeth with clinical attachment loss not due to any of those conditions mentioned, so we're gonna say it's a periodontitis. So we're gonna do the charting. So first of all, we're gonna do probing depths. If the probing depth is 4 or more, we're gonna say yes, so it's a periodontitis case, and then we're gonna speak about periodontal bone and appraisal and how to deal with it. But if the probing depth is not than 4, so you go to probing depths and check the probing depths. If there is bleeding on probing, so you're gonna say gingival inflammation in a periodontitis patient. If it's reduced but healthy, if there is no bleeding on probing, so you're gonna say this patient had a periodontitis before, and as we said, a periodontitis is a factor of life. Periodontitis patient will stay periodontitis patient forever, so he has reduced but healthy periodontian patient. So I hope this is clear for you. I know it's a little tricky, let me say it again. So periodontitis is a factor of exclusion. We're gonna say if you have clinical attachment loss, you're gonna think about any other factor leading to this clinical attachment loss, including endoperial region, vertical root fracture, faulty restoration, caries, impacted wisdom tooth. If it's not due to this stuff, and you see it's kissing lesion, you assess gingivitis and monitor. If it's not kissing lesion, like it's away from each other, so you're gonna say it's periodontitis. And then you're gonna speak about the probing depths. If it's 4 or more periodontitis, let's give staging and grading. If it's not 4 or less than 4, you're gonna check bleeding on probing. If bleeding on probing is present, so it's gingivitis in a periodontitis patient. If it's not present, it's reduced but healthy periodontian patient. Okay? Please listen to it again. If you listen to it twice, I think it will be easy for you to conclude everything. So we're gonna speak about the periodontitis first and then speak about the other one. So we're gonna speak about periodontitis. We're gonna see the extent of the teeth. If it's less than 30%, we're gonna say it's a localized periodontitis. If it's more than 30%, you're gonna say it's a generalized periodontitis. And then severity and complexity. So we said like it's 3 categories. We're gonna staging, extent, and grading. The extent is generalized or localized depending on the set of inclusion. If it's less than 30% localized, more than 30% is generalized. And then I can speak about the level of bone and clinical attachment loss. If you have any factor modifying it, if you have class 2 or 3 forcation, you're gonna say, okay, it's stage 3 or 4. If you have class 2 or 3 forcation, you're gonna say, okay, this one go directly to stage 3 or 4. If you don't have class 2 or 3 forcation, and the pocket is not deep, no deep pocket, it's just 3 to 4 millimeter, so it's a period tooth loss, you're gonna say this is stage 1 or 2. So to wrap it up for you, we're gonna say it's more than 4, it's a periodontitis patient, and then we're gonna see a different factors pushing us to put in 3 or 4. If you don't have this factor like forcation class 2, forcation class 3, not a history of loss of teeth recently due to periodontitis, the teeth was mobile, so you're gonna say it's 1 or 2. If you have factor like make you think it's more complex, so like class 2 forcation, class 3 forcation, probing depths more than 5, so you're gonna say it's class stage 3 or stage 4. Okay, and go back to the first step. We said like if you have the probing depth, so you're gonna check if this patient has a history of previous record available, you check the previous record available before, and you check the numbers you have now for the previous number. You see the progression is fast. You see this patient came to you 6 months ago, you have probing depths of 4, 5. Now he came to you after 6 months, you see a probing depth of 6 or 7. So he has progression which is fast, so you're gonna for sure make him go to grade C. If you have the progression of loss is less than 2 millimeter in last 5 years, you're gonna say it's a grade B. If you have no progression, it's less than 2 millimeter, is you have no progression at all, so you're gonna say it's a grade A. For sure, in clinical perspective, grade A periodontitis is not existing. Grade B is most commonly the patient, or grade C is the loss is more than 2 in the last 5 years. And then for grading is so easy. You have other factors that will like make your life easy to go for say a stage 3 or stage B. If your patient is a smoker and he smoked 10 or less, so you're gonna say him stage B. If your patient is smoker 10 or more, you're gonna say he's a grade C. And same for diabetes patient. Diabetic patient, if he's controlled less than 7, he's grade B. If he's more than 7, it's a grade C. My recommendation for you here to think about every periodontitis patient as a grade B, and you think about factor to make him go grade A or grade C. Most commonly patients are grade B. If you have in the question factors like pushing you to be in grade C, like smoking 10 cigarette or more, diabetic which is 7, and I want to say 10 because if it's 10 it's C, not like it's less than 10 it's B. If it's 10, exactly 10 it's C. If he's his level of diabetes is not controlled and he's 7, so you go it's C, not B. Okay, like same we said before in the staging, if you have class 2 or 3 forcation, you go to stage 3 or 4. And this is the in the article also about the how you can determine the staging. So we have more than one factor to speak about it to say stage 1 or 2 or 3 or 4. Let's go one by one. First is the interdental clinical attachment loss, and I want you to pay attention to interdental because this like give you evidence about what we said before. It's not every increase in probing depth is qualifying your patient to periodontitis. It's interdental clinical attachment loss. So you go to the greatest site of of loss. If you have cal 1 to 2, it will be stage 1, 3 to 4 stage 2, more than 5, you go to stage 3 or 4. And then your geographic bone loss or PL, if it's less than 15%, 1, 15 to 33, 2, more than 33, he go to stage 3 or 4. And you see a history of tooth loss. If he has a history of tooth loss or 4 teeth or less, so it's stage 3. If it's more than 4, he will be stage 4. So I want you to pay attention. It's like 4, he will remain in stage 3. So if I give you a question saying a patient has mobility grade 2 with forcation grade 2, and you see this tooth is doomed, need to be extracted anyway, and this tooth is like resembling 4 in his mouth, he will still qualify as stage 3. But if the question mentioned he did extraction for more teeth in the last 1 year due to mobility, due to periodontitis, so he will qualify to stage 4. And then the last factor, which is most commonly used factor, is the probing depth. The probing depth in stage 1 maximum will be 4, in stage 2 will be 5, and in stage 3 will be more than 5, 6 and more, with vertical bone loss more than 3, and as we said before, 4 is the greatest one. So think about it here, like in grading, you think every patient is stage 2. He has a probing depth, max probing depth of 5. unless you can get him down to be stage 1. If the max probing depth is 4, for sure without any other clinical factor leading to increasing in probing depth. Or if it's more than 5, 6 and up, so you think about him stage 3, and then you add to his story to give him in stage 4. So again, when you speak about the grading, it's the same. Every patient, and this is not like my conclusion. If you read it here, it's like mentioned specifically. Clinicians should initially assume grade B disease and seek specific evidence to shift to grade A and C. Because I see most dentists, what they are trying to do is trying to memorize numbers. I don't want you to memorize number. I want you to understand the rationale here. This article and this new system is aiming to make your life easier. You are not here to memorize everything, go for every details, going for this. No, you are here to know it and understand it. Because in AFK exam, you will be faced with a question, clinical perspective. He will give you information about it. And here, you can read it here again. Initial stage should be determined using clinical attachment loss. This is a new factor. This is a main factor for you. As I told you, you go, most commonly, it will be stage 2, 5. So if it's less than 5, 4, you go to stage 1. If it's more than 5, you go to stage 3. And then you add more as you go. If clinical attachment loss is not available, you go to radiographic bone loss. The question should mention one of these 4 factors. He cannot let you aim in the darkness. So he will give you one of these 4 factors so you can reach conclusion. Or he giving you 2 slots due to periodontitis before, modify stage definition. Or more complex factor. He told you this patient has a severe ridge defect, like here in stage 4 you can read severe ridge defect, or by collapse drifting. He has less than 20 remaining teeth in his mouth. So you will not be waiting for a question to give you he has clinical attachment loss of 2 with radiographic bone loss of 15 and max probing depth of 4. This is not going to happen. This is not the clinical scenario, and this is not the AFK exam question. He will give you one of those factors maximum. He will give you 2 and want you to conclude. So you should have a baseline in your mind. You go for stage 1, it's 5. Less than 5, you go to stage 4. More than 5, you go to stage 3, and then you're building the story to go for stage 4. Same for grading. You will assume it's a grade B, and again, it's not my conclusion to say it. You can read it here, and I speak with more than one hygienist. Like, I told him, man, like, do you remember every number here? He told me no. He said, like, to me, this rationale of thinking, which I think is practical and will be beneficial for you in the exam. You should not aiming to memorize every number, to read it and write it down for you. No, you should know the exam question style. It's a clinical factor. He will give you clinical scenario which you need to apply your knowledge for. So here the progression. If you have radiographic bone loss or clinical attachment loss, no loss over 5 years will be grade A, which is, you say this Cristiano Ronaldo is not existing in your exam. Or he has this bone loss less than 2 millimeter in the last 5 years, and for sure you have record keeping for this. He's stage B. If it's more, he's stage C. And the bone loss by age. So this is the critical part. Like, let's keep this at the end. So the other 2 risk factor is smoking and diabetes. He's no smoker A, less than 10, he's B, more than 10 is C. And I want you to pay attention, it's just 10. So if it's 10, he go to C, because like it's less than 10. And HbA1c is less than 7. So 6.5 is B, 7 is C. Or no diabetic, he will be stage A. So the last 2 factors was like, if the question didn't give you any mention, he didn't mention smoking, he didn't mention diabetic, he didn't mention radiographic bone loss, you are not aiming in the darkness. So there is a specific formula which I can tell you about it. This specific formula saying you are going to assess the bone loss by age. So meaning, like, I want you to pay attention here, because this is not frequently asking in the exam, but you might be faced with one question, lacking information. He giving you information to go, okay, this is stage 2 or stage 3. But when you read the question again, there is no mentioning of smoking, diabetes, nothing. How are you gonna conclude? So you go to the question, you will see his age, and you see the probing depth. So you're gonna conclude and say it, and this is like a rough formula. It's not like written on the stone. So they concluded, and I speak about hygienist about this, and he told me the secret. He told me we assume that the probing depth, like the length of the root, is to be 13. So, and you go to the probing depth, the maximum probing depth. and you're gonna make a formula. Like think about it this way. So if I'm telling you the maximum probing depth is 5, and it's by 13, so 5 by 13 is less than 50%. So, and you're gonna divide this number by his age, meaning if the probing depth is 5 and this patient is 60 years old, so it will be less than 0.25, so it would be between 0.25 and 1. Think about it this way. It's 5 divided by 13, so giving you almost 40%. Dividing 40 by 60%, like 40, the percent of bone loss, by 60, which is his age, so it will fall between 0.25 and 1, so you're gonna say it's stage B. So the same question, same probing depth is 5, but I'm telling you his age is 25 years old. His age is 18 years old, so it's a different answer. Because like if you divide 5 by 13, it will be 40 again. But when you divide 40 divided by his age, which is 18 or 20, it will be rapid. So it will be grade C. And again, this is not like a secret. Like there is a formula which you're gonna use when you are faced with a question with no information about this one. Anyway, if you don't have information, you're gonna assume he's grade B unless you have very clear evidence he's going to be grade C. Okay? Okay, I know this part was heavy. I would like you to pause the video here and think about it. Go to your notes, answer the question, and then move on. Okay? And then we're going to speak about the other systemic condition, which is periodontal manifestation of systemic disease and developmental and acquired condition. We said this category is equivalent in gingivitis for the gingivitis due to pemphigus vergalis, mucous membrane pemphigoid, and other condition leading to this. This one is including the first factor, including we said papillary cyclic neutropenia, other condition leading to periodontitis, or other periodontal condition which include the periodontal abscess and endoperiolesion lesion, or the mucogingival deformity and condition around the teeth. Some patient have gingival phenotype, which is like thin gingiva. Patient has gingival soft tissue recession, lack of gingiva, decreased vestibular depth, aberrant frenum or muscle position, gingival excess, abnormal color, condition of exposed root surface. And as you can see here, whatever is mentioned here, want to exclude every reason or condition leading to bone loss. So this is like, again, in line with the theory I told you before. Diagnosis of periodontitis is by exclusion. If you can say this bone loss is due to anything, so it will be periodontitis, providing it's two non-adjacent teeth. Okay, and then the last thing is traumatic occlusion. You have primary occlusal trauma or secondary occlusal trauma or orthodontic force. For sure, orthodontic force is due to patient doing ortho and the dentist is giving him like hardwire, giving him high force, leading to this bone loss, or the primary occlusal trauma or secondary occlusal trauma. And then the lastly, we're gonna speak about prosthesis and tooth-related factor that modify or predispose, like localized tooth-related factor, like which mean like think about upper canine, which is like labially inclined or labially erupted. So this canine will be exposed more to the forcible brushing, and not even forcible. Like if the patient is doing gently, but this canine is going up, is going more labial, he will be exposed more to the forces of brushing, leading to more problem. Or localized dental prosthesis related factor, which is meaning faulty restoration, a crown margin ending subgingivally, restoration extending subgingival margin, leading to all this condition. Okay. Last thing to speak about today is peri-implant health. So you're gonna say peri-implant health, peri-implant mucositis, and peri-implantitis. And again, think about it this way. Peri-implant mucositis is equivalent to gingivitis, which is factor of bleeding. Peri-implantitis is equivalent to periodontitis, which is a factor of attachment loss, or not here, it's gonna be bone loss, not attachment loss. So here is like picture can give you the whole idea. Healthy implant, you see the gum is good, bone level is amazing, emergence profile is good, everything is good. When you go to peri-implant mucositis, you see the gingiva is red, is inflamed, maybe it's little swollen here. If this patient didn't go to the dentist, go for oral hygiene measure, it will proceed more to be bone loss around it, so it will be peri-implantitis, not mucositis. Okay? And here is the definition. Peri-implant mucositis is characterized by bleeding on probing and visual signs of inflammation, While there is a strong evidence that peri-implant mucositis is caused by plaque, there is very limited evidence for non-plaque induced peri-implant mucositis, like not very evident, not strong evidence about it. Peri-implant mucositis can be reversed with measures aimed at eliminating the plaque. Again, the plaque here is a criminal. If you do cleaning here, if you do everything, he will go back to be a healthy patient, happy records, everything, everyone is happy. If this patient discard your advice, he didn't follow the oral hygiene measure, he will end up sadly in this sad picture. When you see this picture, you feel so sad for the dentist hated this implant. Okay, peri-implantitis was defined as a plaque-associated pathological condition occurring in the tissue around dental implant, characterized by inflammation. So its next step, he's going to like reach to Toronto now, peri-implant mucosa and subsequent progressive loss of supporting bone. Peri-implant mucositis is assumed to precede peri-implantitis. Peri-implantitis is associated with poor plaque control and with patients with a history of severe periodontitis. Onset may occur early following implant placement as indicated by radiographic data. Okay, peri-implantitis in the absence of treatment seem to progress in a non-linear and accelerating pattern because that is at the end of the day the bone here is enclosing a foreign body implant. Whatever osteointegration is happening here, it's a foreign body. When you have infection going from up down, the bone loss will be like progression of the bone loss here will be like fast, very fast. I hope that would be beneficial for you. Thank you for finishing the video till the end. I know this lecture is super heavy. I know. I tried my best to explain more, give you some example, give you some stuff you need to remember to stick in your mind. Now you are studying for AFK exam. AFK exam, for sure you're gonna be faced with at least 4 or 5 questions from this concept. Please do not memorize number. I tried memorize number for a very long time. I failed my exam because I was just memorizing the number, looking gingivitis, looking for smoking, looking for stuff. And then when I did study again, I speak with a hygienist. He gave me this diagram. He gave me the idea to think about it. It's stage B, it's grade B, stage 2. Either you have factors to go stage 1 or push you stage 3 or 4. Either you have factor pushing you to be grade A or pushing you to be grade C, and then give you a secret formula. If you don't have factors, you think about it. This one is not like from my imagination. There is a formula that hygienists are using to conclude the grade for the patients. I hope that will be beneficial for you. Feel free to leave a comment or ask more questions about it. Share the video with other dentists going to exam, and have a good day.